Hey everyone, and welcome to this explainer. If you clicked on our thumbnail for the AIMS CRE 5 OT Technician Exam memory-based answers, you are in the exact right place. We're turning that massive, overwhelming list of scattered memory-based questions into your ultimate high-yield study guide. We've taken all those random facts, structured them logically, and set them up so you can just effortlessly absorb them. Because let's be real here, rote memorization, it's completely exhausting. If you want to conquer this exam without the cognitive whiplash of just staring at flashcards, you need a system. When we organize information visually and connect the dots, your brain actually holds on to it. So today, we're building a solid mental framework that you can carry straight into that examination hall.
So, here's the game plan. We are chunking these 100+ questions into 5 easy-to-digest clinical buckets: essential gases and equipment, must-know anesthesia drugs, airway and emergency protocols, patient positioning, and finally, general knowledge. Let's dive right in.
Kicking things off with Section 1, Essential Gases and Equipment, we're heading straight into the operating theater to look at the crucial hardware and everyday color codes you absolutely have to know.
You know how it is in the OR. Colors are literally a universal language. You need to map these out in your head. Oxygen pipelines, always white. Nitrous oxide, blue. When you're reaching for IV access, a 20-gauge cannula is pink, whereas the tiny 24-gauge used for kids is yellow. And for waste, your used gloves go straight into the red bin, but their paper wrappers, those go into the black bin.
Now write these numbers down and never forget them, 2 and 5. This is the Universal Oxygen Cylinder Pin Index. This mechanical standard exists for one very specific, life-saving reason: to prevent disastrous connection errors. Because of the 2-5-pin index, you physically cannot attach the wrong gas to an oxygen yoke. And that brings us to the Link 25 system found on OMETA anesthesia machines. This is such a brilliant safety net. It mechanically links the oxygen and nitrous oxide flow control valves. Why? To guarantee we never accidentally deliver a hypoxic mixture to our patients. It literally stops the fresh gas mixture from dipping below 25% oxygen. The machine is watching your back, but you've got to know how it works for the test.
Okay, vapor pressures. Examiners love asking about this. Just lock in this descending order. Desflurane has the highest, followed by isoflurane, and then sevoflurane. But don't just memorize the list. Think about the clinical side. Sevoflurane is the preferred rapid elimination agent for pediatric induction because it smells sweet and is way less irritating to a child's airway.
All right, moving right along to Section 2. Let's build up your pharmacological foundation with the must-know anesthesia drugs.
Let's talk propofol. It pops up constantly in both image-based and theory questions. Yes, it's our most common IV induction agent, but for the exam, you must remember its formulation. It is an egg-based lipid emulsion, which is a big deal for patient allergies. Also, if they ask about critical care, remember that continuous ICU infusions carry a massive risk of PRIS, propofol infusion syndrome.
You're going to see this next concept over and over because it happens practically every day. The absolute most common complication of spinal anesthesia? Hypotension. The sympathetic nervous system gets blocked, and boom, blood pressure drops. Your go-to drug to fix this, especially during a C-section, is ephedrine. Just link those two concepts in your mind right now. Spinal block equals hypotension, which equals ephedrine.
Sticking with OB and neuroaxial blocks for a second, lock these 3 specific drugs in. Ropivacaine is the favorite local anesthetic for epidurals. If you're using epidural morphine for pain relief, you have to remember it carries a sneaky, delayed risk of respiratory depression. And after delivery, we rely on oxytocin to maintain uterine contractions and stop bleed.
Section 3 is where things get intense. We are looking at the exact protocols for when seconds truly matter in the OR: airway and emergencies. Picture this: you just intubated. How do you prove that tube is actually in the trachea and not the esophagus? The absolute gold standard is detecting end-tidal CO2, paired with seeing the chest rise and checking for vapor in the tube. Oh, and bonus tip: if you're putting in a simple oral airway before intubation, size it by measuring from the corner of the patient's mouth to their earlobe.
Now imagine you're watching the monitor during a case and bam, the EtCO2 trace just flatlines to 0. What is your very first thought? It has to be an ET tube disconnection or a massive airway obstruction. It's a high-stress scenario, and it requires instant action.
And speaking of those monitors we stare at all day, whenever an examiner asks for the physics behind that glowing red SpO2 probe on the patient's finger, the answer is always the Beer-Lambert law.
It's simply how light absorption by the blood tells us the oxygen saturation. Okay, worst case scenario, a patient crashes. Your basic resuscitation has to be automatic. For CPR, your hands go to the center of the chest, just below the nipple line. Your primary life-saving drug is adrenaline, dosed at 1 milligram every 3 to 5 minutes. And remember, if a patient has severe antibiotic anaphylaxis, adrenaline is once again your absolute drug of choice.
This next one is highly specific but absolutely critical. LAST, or local anesthetic systemic toxicity. If you accidentally hit a vein with a large dose of local anesthetic, it can trigger seizures or cardiac arrest. When that happens, grab the 20% lipid emulsion from the crash cart immediately. It works like a sponge, drawing the toxic local anesthetic right out of the patient's tissues.
Let's pivot a bit to Section 4, Patient Positioning Basics. This gets heavily tested because a bad position on the table can cause serious, long-term nerve injuries. Examiners are obsessed with these mechanics. Reverse Trendelenburg, head elevated, feet lower. If a patient is prone, you must ensure their abdomen is completely free from pressure so they can breathe normally. And for the lithotomy position, the cardinal rule is that 2 people have to lift and move the legs at the exact same time. It's non-negotiable to prevent severe nerve damage in the hips.
And finally, Section 5, General Knowledge and Aptitude. Let's do a rapid-fire round to grab those easy points that'll boost your overall score.
Okay, speed round. The Missile Man of India, APJ Abdul Kalam. Smallest state? Goa. The national flag length to width ratio is strictly 2 to 3. Largest freshwater lake? Wooler Lake. The highest gallantry award? Param Veer Chakra. And throw in some geography, like the Sutlej River housing the massive Bakra Nanga Dam. Drill these in, and those extra points are yours.
They're also going to test basic computer literacy. For MS Excel, keep in mind that proper is a totally valid text function used to capitalize words. But strangely enough, subtract is not an official named function. To subtract, you literally just use a minus sign. It's a trick question they love to throw in.
And for basic aptitude, it's all about quick mental math. If 3 pens cost 18 rupees, you just divide 18 by 3, so 1 pen is 6 rupees. Multiply that 6 by 7, and 7 pens will cost you exactly 42 rupees. It's super simple, but under exam pressure, mapping it out step by step stops you from making silly mistakes.
As we wrap up this explainer, I want you to think about this. Knowing the answers for the exam, like knowing hypotension is a spinal complication, is just step 1. But applying those facts in real time, catching that blood pressure drop or that disconnected ET tube before the monitor even has a chance to alarm, that is what makes you an exceptional OT technician. Keep this framework in mind, review these key concepts, and you aren't just going to pass the CRE 5, you're going to be a phenomenal clinician. You've got this.